Good morning, fellow doctors. My name is Diajeng Soeharto, and today I'll be presenting the findings of our systematic review and meta-analysis entitled Binocular Therapy for Amblyopia in Children. The study was supervised by Dr. Julie Dewi Barliana and co-authored by Dr. Abrito Zaifar and Dr. Natasha Priscilia Wibowo. As we know, early treatment for amblyopia is absolutely essential, and despite recent advancements in amblyopia therapy, mainstay treatment remains the same. What with its drawbacks, there remains a gap for novel therapies for amblyopia with good efficacy that also encourages better adherence. This is where binocular therapy is thought to come into play. Binocular therapy aims to promote binocular fusion and stereopsis by providing stronger stimulus to the amblyopic eye, in turn allowing for improvement in visual acuity as well. In recent years, binocular therapy has emerged in various platforms using dichoptic stimuli and contrast rebalancing in the form of games or passive video watching. Therefore, the objective of the study is to evaluate the efficacy of binocular therapy in comparison to standard amblyopia treatment in children. The methods of our study are as follows. We conducted a comprehensive search across 5 different electronic databases using keywords selected a priori. They included studies written critically appraised using the Cochrane risk of bias for RCTs or ROV2 tool. We only included studies that were randomized controlled trials conducted on children with amblyopia given binocular therapy only in comparison to standard amblyopia therapy and must include the primary outcome of the study, which was change in amblyopic eye visual acuity from baseline. We also included secondary outcomes, which were stereo acuity and adherence. Moving on to the results and discussion portion. This Prisma diagram summarizes our search findings, in which after going through the processes, we narrowed it down to 15 RCTs that were eligible for inclusion. This table summarizes the baseline characteristics of our included RCTs, in which the studies were published from the years 2016 to 2023. Studies highlighted in yellow indicate that they were assessed with some risk of bias according to the ROB2 tool, and those studies highlighted in green indicate that they were of low risk of bias. As for the study population, most studies included all types of amblyopia. However, there were 4 studies that specifically focused on anisometric amblyopia alone. Most studies included patients with history of amblyopia treatment, although there were 3 that only included treatment-naive patients. As for treatment regimen, most of the studies implemented game-based binocular therapy, although 3 of the most recently published studies used video-based binocular therapy. As for control, most of the studies used patching, while some only used full-time refractive correction as their control. Study duration varied from 2 weeks to 16 weeks. This forest plot summarizes the change in amblyopic eye visual acuity from baseline, and as shown here, overall visual acuity change between binocular group and patching group is not statistically significant. However, subgroup analysis of treatment duration revealed that at 2 weeks, subgroup analysis revealed significance at 2 weeks favoring binocular therapy. However, we noticed diminishing mean difference with each follow-up, and at 12 weeks, patching was significantly more favorable than binocular therapy. This is in line with past studies, which suggest that patching requires a longer time in order to be more effective. Subgroup analysis on type of binocular therapy revealed that video-based binocular therapy may be more effective than patching alone. However, this finding was not statistically significant. As for game-based binocular therapy, results did not show a discernible pattern, and this result was also not statistically significant. In comparing binocular therapy to refractive correction alone, it shows that binocular therapy is significantly more favorable. However, past meta-analysis revealed that spectacles treatment is only superior to optical penalization. Stereo acuity was reported only in some studies with contrasting results, with only 3 studies that reported significant stereo acuity improvement in the binocular group, yet there was no significant change in their patching group. Other studies showed either no differences between the groups or no changes in both groups. As for adherence, it varied quite largely between the studies, as shown here, with the lowest rates of adherence reported in 2 of these studies, which were parallel studies using the same intervention. Some studies also conducted secondary analysis on visual acuity change in relation to adherence to therapy with contrasting results, with these studies reporting no significant association between adherence and efficacy of therapy, while these studies reported that there was a significant association between adherence and efficacy. Therefore, the relationship between duration of treatment and efficacy in terms of visual acuity change is still undetermined. Although our analysis suggests that binocular therapy alone may not be sufficiently superior than patching, several studies have revealed that combination therapy, which is binocular therapy and patching together, may be significantly superior than patching alone, be it in terms of stereo acuity improvement or visual acuity improvement. This study therefore provides a comprehensive analysis on the most updated literature on this topic and provides insight on the most novel video-based binocular therapy, which was not included in past meta-analysis. However, some limitations include the varying modes of intervention and control, small sample sizes of the individual studies, and the inherent risk in most of the studies. In conclusion, current evidence suggests that binocular therapy may be beneficial. However, its efficacy as a standalone substitute for conventional therapy is not yet substantiated, and further studies to determine the most effective treatment protocol is still needed. Thank you very much for your time.